How would you like to listen to that all day? Oh, what happened? Huh? So what is the prevalence? Well, alarm desensitization or alarm fatigue. Hold on, we're trying to figure out. We've got technical trouble. That's okay, just leave him ringing. You know what?
Let it ring. He's desensitized. Those are his types of cases.
Let it ring.
I don't know how I mean. We don't hear it anyway.
Yeah. Mining, the nuclear power industry, and of course, in healthcare. I want to read some of these to you. These are great. I'm going to read them all. Effects. The nurse went to check on the patient. Patient was put back on monitor. Patient was in a systole. A code was called and staff were unable to resuscitate the patient. Elderly female brought to emergency department. She was inadvertently off telemetry when she was found unresponsive and expired. A patient was admitted through the emergency department. Admission orders include telemetry monitoring. Nurse entered room and found patient unresponsive. A code was called and the patient was transferred to the intensive care unit. Later, the patient coded again and expired. Discovered that telemetry monitoring was never initiated on admission to the floor. A nurse responded to the patient's intravenous pump alarm and found the patient unresponsive and pulseless. Cardiac leads were found to be disconnected from the monitor cable. The physician was immediately notified and the patient was pronounced dead. So what are these continued effects? Well, in one 12-bed ICU studied, there were between 150 and 400 monitor alarms per patient day, which equates to, that's per patient per day, 1,800 to 4,800 alarm episodes in any given day. Patients were either in this particular unit, 1-to-1 or 2-to-1, and it was determined that each nurse in that unit was exposed to that number of alarms times all 12 patients each and every day. Well, the hospital is flush with alarms. One study done at the Johns Hopkins Hospital identified 59,000 alarm conditions in a 12-day period, or a staggering 350 alarms per patient per day. With all these alarms, it's no wonder that nurses and other healthcare professionals suffer from what is known as alarm fatigue. This is great. One notorious case involves a patient whose telemetry battery died. Before he went, I didn't click it. Oh, sorry. Let's start off again. One notorious case involves a patient whose telemetry battery died before he went into cardiac arrest. The telemetry unit quietly beeped for 75 minutes, low battery, beep, 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 before shutting down. Unfortunately, the man was found dead and cardiac resuscitation was never performed. Clearly, dead and stiff.
Oh my God.
Dead for
Bring batteries.
Dead for a while.
Yeah, bring
dead
batteries,
for a while.
yeah.
Well, the parameters, how does this happen? The parameters get changed. Okay, the alarm keeps going off and the pressure is 100, I'm going to turn the alarm down to 90.
Yeah.
And then we're going to turn it down to 80. We're going to stop this thing from going off.
Balloon pump.
We silence them.
Yeah, we do.
Okay, we just the silence button, silence alarm. And sometimes you can silence them for indefinite periods of time.
Correct.
Okay, or we just simply turn them off. But the real killer is you just stop hearing them. It's going off and blaring, and you have just simply blocked it out. Why?
Yeah.
Because it's the boy that cried wolf. 85% of hospital alarms are false.
85%?
85%. Let that sink in.
Yeah,
85% of hospital alarms are false. Well, as humans, psychologically, it's the whole, Aesop's fable, the boy that cried wolf. We just don't even believe them anymore. We just start ignoring them. So in perfusion, in the OR, generally this is not really a problem for us as perfusionists. It is a huge problem for nurses. In fact, we'll talk about that a little bit, but there's initiatives on this. This is a huge, huge problem. Patient injury secondary to alarm fatigue is a very, very big, real problem that's being addressed right now with JACO and some other folks and the ECRI Institute, and we'll talk about those kind of going on.
Why do you say it's not a problem for perfusionists?
Well, in the operating room, we don't really have that many alarms going off. We're doing one patient, one procedure. It's a shorter period of time. It's a more intimate environment. Really, I think in the operating room, we're not, you heard that you'll hear it again as I move forward. I'm going to play it as my last slide. And hopefully this time, Roger, if you would, just turn it all the way up. I want everybody to really feel what it's like to have these alarms just blaring constantly, the IV alarm, the monitor alarm, the EKG alarm, the blood pressure alarm, the whatever alarm, the fire alarm, the this alarm. People don't even respond to fire alarms anymore.
True.
The fire alarm goes off and we're all just like, it's another false alarm.
Yeah.
What's going to happen the day when it's not?
Right. Yeah.
It's real. Okay, so anyway, but, that's my view in the opera. I think we do have to be concerned about it. In the ICU, I think it's a bigger problem when we're monitoring ECMO patients. I think in those circumstances, you have all the other rooms going on at the same time, plus your patient. Which alarm is it? You have to identify where it's coming from. What is that alarm? The ventilator alarming. Does that something I need to address? And I think that over time, you just become desensitized to all of these alarm conditions. So what is being done about this? Well, the Joint Commission is saying they'll take appropriate measures to reduce the number of nuisance or false positive alarms. Well, that seems to make intuitive sense. If 85% of them are false, it seems to me that, we need to address that issue. Clarify who is responsible for alarm notification and response. We could talk about that in the discussion period because I don't know what that means. Build a culture of safety. Well, that seems fairly commonsensical too. Carefully analyze and measure potential alarm-related problems. Well, again, that seems to make a lot of sense. And develop clear protocols for handoff communication. That really, I don't know how that, this is what JACO is saying. I'm not a JACO expert, but this sounds like a bunch of gobbledygook to me. It sounds more like the handoff communication is more relevant to us going when if we're having to be relieved on a procedure and what procedures do we take for that. But there is something to say with that. I don't know, the handoff communication. I've got bed 2 and you're going to be taking the patient and Patrick, the alarms are going off all night, but I've just been ignoring him. The patient seems still to be fine. Good luck. ECRI Institute is also working on the problem. The ECRI Institute, I think they're looking for ways to have devices be able to interpret, is this a real or false alarm? But technologically, it's very, very complicated. It's a really big problem, but still does need to be addressed. And I'm going to go to my last slide, and I want everyone to really absorb this slide. And then we'll go into a discussion period and you guys can call in or we can chat or whatever you want to do. And I'll go back to the YouTube chat to see. So here we go. We'll go to our last slide. All day long, this is happening at different times. And you have to filter all of that out. Alarm fatigue is a real problem. I don't have any solutions to it, but I think the one thing that I would suggest is we need to at least recognize that it is a real problem and not become complacent about when we hear alarms, because the likelihood, though slim, I don't think I could live with myself if I ignored an alarm and only to go in there to find out that it was really a problem.
Yeah.
So thoughts? I'll go to the chat, comments. Any of you guys want to elaborate on my content?
I wonder about, people talk about AI a lot, artificial intelligence, and you were talking about some of the organizations talking about making these devices more smart so that we don't have 85% of false alarms. And hopefully maybe technology could take that over a little bit for us in the future. But we still have an immediate problem with alarm desensitization.
Alarm fatigue.
Alarm fatigue.
I had a
That's
hard time
easier
with
to
that
say.
one
Thanks.
too. Yeah, exactly. Far fewer syllables. What's your thoughts? Is any nurses out there watching call in, or anybody who may be married to a nurse call in and give us some thoughts?
No, obviously it's a real thing. You know, even the surgeons get the fatigue, and at least they have the power in saying, like, shut that stuff off. True.
Isn't that true?
You know, I have a surgeon that I mean, he's got ears like a bat, and just goes off. And I go, well, that's for my purpose. He goes, well, it's not for my purpose. So he gets the fatigue, and you know what? There's a lot of times where I turn it to 0. I mean, I just have to be that much more diligent, and that it could be my pump, it could be the balloon pump. I mean, I do have that desensitization. I mean, it happens. It just happens.
You don't even hear it. He hears it.
He hears it. No, I'll hear it. Oh, I hear it because I know that because the follow up isn't such a nice statement. You know, shut the blank off. So I'm sensitive to that versus an actual alarm. But so I'll shut off some of my alarms. The erroneous alarms, ones that won't affect my patient care.
Well, we have an ER nurse, you know, who's now a CRNA in the audience. As a matter of fact, here live in the studio audience, who's operating camera number, I think it's number 2. What are your thoughts? You want to call in?
Sure. She can talk to you.
Oh, she can talk right here. She can give you the microphone. So we have someone in our live studio audience. It's Vicky. She won't get in front of the camera though, but I could just have David twist the camera around.
I'm here. Can you hear me?
No, not yet. Oh, I can? Okay, good.
I have experienced the same thing Rodel's talking about, where in surgery, the physicians, the surgeons don't want to hear the alarms going off because they get worried. They don't know what they are. And it may be that you have one of the 5 EKG leads disconnected, and it's going to alarm, but the EKG defaults to another lead, and everything's fine, and you can't reach down there right at that moment and reattach the EKG wire. But everything's okay, but they don't know that everything's okay. They just hear alarms, and any alarm to them, it doesn't matter which one it is worrisome to them. And
but they're there to protect the patient. I understand it's worrisome to them, but
so where's the balance?
Right, but if
I don't have the answer to that.
Yeah, I mean, everything to me, has sort of changed a little bit, now that I am not only a practitioner, but also a business owner. And I look at this from not just, of course, a patient safety perspective, which I think all of us that are in this room and those participating online are patient safety advocates. But, so that's first and foremost. We have to do what is in the best interest of the patient. But secondarily, if something does happen and it is determined, and it's always easily found, that you turn the alarm off, even if that specific alarm was not necessarily the cause of the problem, where is your liability? Where's our liability?
Yeah.
Vicky?
I think anytime you choose to turn an alarm off, it's your liability.
Right, not the doctors
Right.
who's doing the procedure who told you to turn it off.
Correct.
That's right. So that's where I start to get a lot of heartburn over this subject, because I think that is the common thread, that we just turn the alarm off.
Well, and this is just in my mind talking about alarms, but a lot of the surgeons like listening to their favorite tunes
Right.
in the operating room,
Yeah.
And not alarms, and not having it interrupted.
And usually it's anesthesia that's responsible for the radio, so it's right over there on the anesthesia machine. And you know, if it was across the room, it wouldn't probably be as impactful. But sitting right on the anesthesia machine and to be loud enough for them to hear it sometimes overwhelms the alarms. And you know, and then you have to compensate for it. You have to turn your alarms up higher, and then they don't like hearing the
Right.
or not the alarms, but the SAT monitor and the EKG
Right.
monitor.
I
You
mean,
have to-
do you not? I mean, those are really
Yeah.
those are really good points. So, you know, I'm a perfusionist. You're a CRNA. So but as a perfusionist, when I'm in the room doing stuff, getting ready for a case, doing my thing, while you have the patient asleep and they're opening the chest and taking the vein and doing the mammary and everything else, I still hear, when we're watching an echo in the ICU, I hear continuously that boop, boop,
Sure.
Right.
boop. And if I hear it going boop, 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 I know just from the sound, and I'll turn around and look to see what is changed, what's going on.
You prime a little faster.
You prime a little faster.
Right.
You're cutting into my break time. Now,
Okay.
okay, that's not good. Okay, because I want my break. All right, I want
Right.
my break. Okay,
Right.
but if you don't have that audible signal to you and the EKG that you can hear the heart rate, and how do you compensate for it? If they're blaring the music, you can't hear it, they don't want it on, how do you then have to compensate for that? Or do you?
Well, you if it's just one song that they want to hear louder, then you're watching the monitor the whole time.
Right.
If it's that they want to keep the volume up, then you move the radio, you move the sound system to the other side. If it's a really critical time and you can't, you're doing what you're doing and you can't just stare at the monitor, then you tell them,
Right.
I have to turn it down.
Mm-hmm.
I have to be able to hear the SAT.
You know, I'll tell you what, I turn a lot of alarms off, and I do it for the reason, I've never even thought about alarm desensitization, or fatigue, but I do that because then I have to watch stuff.
Right.
Because sometimes you rely on alarms, and I don't really trust the level detector alarm, honestly. I mean, sometimes it works, sometimes it doesn't. You know, bubble detector, same thing. So you really have to watch stuff, and I do turn most of the alarms off. Definitely the flow alarm and balloon pump, that thing's off the whole time.
Could you do me a favor?
Sure.
Stop doing that. Leave them
No,
on.
it helps. It helps me focus. I know
No,
that
I
I
really
have
need
to
you
watch
to- I
these
really
things,
need
and
you
it doesn't
to-
matter how
I-
loud the music is. You know,
No, I really need you to commit. That you'll never
turning
turn
the
them off
alarms on.
again.
But what if I get alarm fatigue?
We'll give you an extra day off
Okay, there you go. That's live. There, you heard that.
Yes.
without pay.
Yes.
Oh, okay.
Oh, forgot that part.
That's fine with me.
But isn't that a good
I've got
argument? I mean,
lots to
that's
do.
a reasonable thing to talk
Right.
about. I don't know how many people turn a lot of alarms off. I don't turn them all off, but I turn a lot of them off.
I turn them down. Like but again, it's Patrick's right. I mean, my scan gets a little bit better when I turn my alarms volumes down. The balloon pump, I get it down to its minimum alarm, and it's usually the augmentation alarm. And I'm sure all the perfusionists or whoever has run a balloon pump, knows how to do that, because that that can always alarm at just erroneous periods of time, or when like the balloon pump is refilling or recalibrating, and you know that alarm can go off for many minutes, and you're getting a phone call from the ICU in the middle of the night, like, how do I shut this off, or how do I fix this? So, you know, I do believe in alarms. It's just not very loud ones.
Of course, you know, I'm older and hard of hearing, so I need them turned up real loud. And I try to watch really carefully, and I use all of Joe Basha. All of my alarms are on at all times. Okay? And very loud.
Yeah. And, you know, I mean,
officially, it's on record.
Right. And you know, it also alerts the surgeon of like the situation at hand. It's like, hey, my level alarm is going off. You know what, Doc, you got to fix that venous cannula.
Right.
I'm sorry. I mean, I can't keep going through this.
You don't want to hear this alarm.
You don't want to hear this alarm. Fix the problem.
Right. Exactly.
You know,
don't make me turn it off and suffer alone. I want you to suffer with me. You know, I think that's a very good point.
Yeah.
Okay. Any other comments regarding that?
I don't think so.